welcome everybody. I don't see the people in Saskatoon yet, but I'm sure I will. I'm sure you're there. My name's Tom McIntosh. I'm here as guest host in replacing Dr. Marchildon. And Greg asked me to introduce John today because John and I have actually known each other now. I was thinking about this for over a decade. For too long, yeah. Partly because we were both involved, and I'll say a little bit about it in a minute, in what was probably the longest research project in the history of our respective careers. But I think it was a project that in the end had a really big payoff for us. So I think it was worth it. John is an associate professor in the Department of Political Science at the University of Alberta, which is also my alma mater. It's where I did my undergraduate degree. He holds degrees from the universities of Guelph and Waterloo, and his PhD is from the University of Western Ontario. And again, as a Queen's grad, I should say something nasty about Western, but I won't. Except to mention that we used to, in the bookstore, sell t-shirts that said Western. Isn't that a sandwich? Anyway, so we also had one that said, "Friends don't let friends go to Carleton." But John's work has been focused almost, but not exclusively, on the politics of healthcare and the challenges of healthcare reform, especially in challenging economic times. And in particular, he's written extensively on the issue of regionalization of the health services, and knows perhaps more than anybody about the strange and curious case of regionalized healthcare in the province of Alberta. And of course, most significantly recently, John is one of the editors of Paradigm Freeze, Why It Is So Hard to Reform Healthcare Policy in Canada, which from McGill Queen's Press and published late last year. And this is the project that we worked on together. And Paradigm Freeze is, I think, a unique attempt to understand how health policy gets made by examining 6 different policy decisions in 5 different provinces, so examining 30 separate case studies through the lens that has become a key part of John's own work of that intersection of idea, interests, and institution. John not only conducted the Alberta studies for the project, but also worked with Harvey Lazar, the project lead, in all of that surrounding roll-up analysis that actually tried to make sense of the very complex stories of how policy got made in these very different political and economic environments over a period of about a decade and a half. And so I would argue, even though I have a vested interest in saying this because I'm one of the contributors to the book as well, that this is, I think, one of the most important books in recent Canadian healthcare policy. And we are very fortunate to bring John here to share with us the lessons of regionalization out of his home province. So I'm very pleased to welcome to U of R and to JSGS, Dr. John Church.
I'm going to be quoting from this later on.
Oh, good. Good.
So if it's any consolation, Tom, my mom graduated from Queen's.
Oh, that's good.
That helps.
Yeah, that helps a little.
So I'm once removed.
Queen's grad went through it.
Thanks, everybody, for inviting me today to talk about Alberta. I'm getting used to the technology here, so I'm a little overwhelmed by it. What's that buzzing noise?
The elevator.
Yeah, okay. Anyway, so for the next while, what I'm going to try to do is, there we go. I'm going to try to walk you through what has gone on in Alberta since the mid-1990s, and then to make some sense, try to make some sense of what's gone on in Alberta since the 1990s. And finish off by talking about what I see as being the good, the bad, and the ugly about what has gone on in Alberta during that time period. And this really is going to be a focus on the politics underlining the process around the development of regional structures in healthcare, as opposed to looking at health services outcomes and that sort of thing. Because I think that in spite of all the effort that has been invested in trying to measure outcomes and try to determine why we aren't getting the outcomes that we think we should be getting, and to focus really on reorganizing clinical processes and things like that, when it all comes down to it, it really is about something other than clinical processes. So first of all, just some preliminary thoughts. When we think about what politics is about, it's basically about power. And those of you who are from a political science background should have been exposed to this in your 100 level political science course. If you weren't, then I'm not sure which course you were taking. But in any event, the definition that I came up with some time ago, because there are all kinds of definitions out there, is a very simple and straightforward one. And this was really based on looking at the way that the medical profession has operated quite successfully in the health policy area. And so the ability to control and manipulate one's environment and everything in it. So if you think in religious terms of some sort of higher deity, or even in science fiction terms of some sort of higher deity, what usually defines that particular entity is its ability to basically control and manipulate everything in its environment. So when you then transfer that into politics, and specifically into health politics, and you look around at what goes on in health politics, basically you've got different interests and different interest groups that are attempting to exert power to maximize their own advantage in that particular policy environment. So just something to keep in mind as we walk through this, and we'll come back to this later on. More broadly, and getting back to Tom's comment about interests, ideas, and institutions, when you think about public policy and you think about what politics is about, this diagram provides you with sort of a good overview. So on the, you've got ideas, which are basically the information sources and value preferences that inform public policy decisions. You've got policy interests, which are basically the actors that interact with each other in particular policy systems, and also the things that motivate actors in the way that they act within that system. And then you have institutions, so government agencies, mandates, accountability, formal processes, legislative frameworks, that kind of thing, and existing policy or policy legacies, as the literature refers to them. And then you also have this other thing to sort of throw in the population health side of things, which is what we call context. So you've got the social context, so the social history of a province or a jurisdiction, the economic history, the physical environment, the environmental aspects, and then you have other things such as gender and culture, which also have an influence. So all of these things are interacting with each other to produce some sort of policy outputs. If you look at the bottom of the diagram, politicians are interested at the end of the day in building the best consensus they have through what goes on in terms of the interaction of these various things. So again, something else to keep in mind as we go through the rest of the presentation. So I think I've gone through this, so I can basically jump over it. The one thing that I didn't mention that sort of brings together the notion of ideas, interests, and institutions and power is the idea that in any particular policy field, you will tend to have certain interests, or even a single interest or an interest group that is dominant in that policy field. You will have other interests that will want to challenge that dominance, and then you'll have other interests that really aren't particularly engaged in that competition at all. And you know, a way Robert Alford wrote about this, a sociologist in the U.S., wrote about this in the 70s and used it as a way of explaining the U.S. healthcare system. And at that time, he referred to the dominant interests as basically being medicine and pharmaceutical companies. And the challenging interests were basically those organizations that were seeking to better manage the system. So in the U.S. system, that would be the health maintenance organization, so the private insurance companies basically, and to a lesser or greater degree government in terms of the regulation the government tries to impose. But in the Canadian context, of course, the challenging interest translates almost entirely over to government because of the way that our system has been organized. So you've got, associated with that, you've got a competing set of values. You've got the values associated with professionalism, particularly around clinical and entrepreneurial autonomy. And then you've got the values of management, which are basically associated with managing the system better. So there's a natural tension between those sets of values. And as we'll see as we go through, there are other values that are running around that are more or less aligned with, with those kinds of values. So just keep those things in mind as we work through, and you'll see how it plays out. So just talking about the background then, in the late 1980s, or by the late 1980s, Alberta was in a significant deficit and debt position. And this really was the result of the downturn, this will come as a surprise to people probably, but in the downturn in the oil and gas revenues in the early part of the 1980s, which resulted in less revenue coming in Alberta. But the government continued to spend and to borrow money to keep those expenditures up. By the mid-1980s, it already started to slow things down, but the damage basically had already been done in terms of the debt that they had racked up. So you can see that by 1993, by the time we get to 1993, they had huge accumulated debt, or huge by the standards of 1993 anyway, and the servicing the debt alone, you can see, rose significantly during that same time period. So this created a political environment in which there was an expectation that government was going to do something to control its deficit and debt. So that would not really occur until the arrival of Ralph Klein. He became the leader of the Provincial Conservative Party in the early 1990s, and then he cemented that through an election in 1993 or 94. I'll come to the chronology in a minute. But in any event, Klein sought to basically reinvent the Conservative Party. And the interesting thing about Alberta is that unlike most jurisdictions in Canada, Alberta tends to re-elect the same political party over and over again. And they have done so for the past 4 decades, since 1970. Now time is marching on here, so nearly, so over 4 decades they have been electing the same political party, the Conservative Party. And basically all they ever do is each political leader that takes over from the previous one tries to reinvent the party so that any of the past offenses of the previous version of the Conservative Party will then be wiped away. And we're currently seeing that in Alberta with Jim Prentice, who has taken over as a new Conservative leader from the former leader and Premier Alison Redford. And the first thing that Jim Prentice has proceeded to do is very systematically to go about basically canceling almost every major thing that the previous political executive did. So there's been a series of almost daily or weekly announcements where something has been canceled that it previously had been pushed through by the previous government. And of course now they're setting about to fix healthcare by announcing the same things that were announced, I don't know, 5 or 6 years ago. So that's kind of the way things operate in Alberta. So it's a bit of somewhat of a different environment from other jurisdictions, although the overall pattern of change in political leadership and reinventing, even if you, for example, if the NDs defeat the Conservatives, you can be assured that the NDs are going to start undoing some of the things the Conservatives did and vice versa. So it's a similar pattern. It's just you never actually do really change ideology. The roads in Alberta only go one way, which is right. There are no left-hand turns in Alberta. They're all right-hand turns. I can say this, I'm from Ontario. I've been there for 20 years now, but as you know, Ontario has somewhat more vibrant political culture than that, as does Saskatchewan. So the kinds of things then that governments were concerned about in those early days were cost control. Obviously, they were concerned with how much money is being spent on public services in general, but healthcare specifically, because at the time it was in the mid-30s as a percentage of the provincial budget. Efficacy, concerned with how the money is being spent, so are we getting the biggest bang for the buck. Coordination and integration, concerned with fragmentation of administration and delivery, which were seen as major contributors to costs particularly in healthcare. And then concerns with being more responsive and accountable, and responsive to local communities in particular, but more importantly perhaps accountable to provincial governments, because there was a sense that the money was going down to local hospitals and other providers of services in the system, and it wasn't making it anywhere. Just a second here, we've got something going on.
Which one is it? Yeah.
So are we still live here?
No. Yeah, keep going.
We're still okay. Sorry, we had a bit of a technical issue here.
Okay.
So, keeping that in mind, what I've just said, we'll move on and I'll just run you through a chronology briefly. So, between 1987 and 1989, there were two major reports that came out. The Watanabe report, which was more of a report that was generated from internally in the Department of Health with some experts involved as well. And then the Rainbow report, which was something that was set up as a public process, and it was done through the Premier's office. So you had the department on the one hand doing their report, and you had the Rainbow report, or the Premier's office on the other hand, doing their report. And there's an interesting political reason around that. The deputy minister, they were trying to get the deputy minister out of the department, so they promoted the deputy minister to running the Rainbow report, and were able to move the deputy minister out. So that was, in a sense, why that happened, although the two processes were fundamentally different. One was very public and the other was not really that public at all. The one report, the Watanabe report, called for the creation of 9 health regions, and the Rainbow report, on the other hand, called for regional coordination among existing agencies. Or maybe I've got the two of them backwards there, but the bottom line is they did not come to identical conclusions about what needed to happen with regionalization. And then in November of 1991, the government responded to the Rainbow report, and it said it did not support the creation of health regions. So I think I just corrected myself there. The creation of 9 health regions was what Rainbow had recommended. And the government itself then responded that it didn't think that creating health regions was the way to go. It preferred the local cooperation route, so decided instead there should be some sort of a role statement process. And I think it's important to, again, fill in some of the backdrop on this. There had been a process going on from the late 1980s into the early 1990s of trying to encourage healthcare providers, particularly hospitals, to voluntarily coordinate with each other. And that would then remove the necessity of some sort of more direct government intervention. And I see Tom kind of chuckling about this here, because getting hospitals to voluntarily cooperate with each other is, yeah, I know. In any event, that was what the government was trying to do at the time, because if they were to move to setting up 9 health regions, it would create major political problems for them, particularly with rural ridings. And at the time, a lot of the political strength in the Conservative Party in Alberta was still based out in rural ridings, even though the urban ridings were, you know, just in terms of their population size and density, they should have had more representation than they did at the time. So they had this dilemma that they had to deal with at the time, and the dilemma was to basically buy time by going through a process of trying to get local cooperation. Well, when Ralph Klein became leader of the party, he fairly quickly moved to end all of that. And in fact, it was kind of interesting, because when I arrived in Alberta as a postdoc, I spent a year over at Alberta Health and Wellness, and some of the supportive work that was done around regionalization, at least the academic work, I did it. So I was inside when a lot of this was going on, and it was kind of interesting, because when I first arrived, I could not use the term regionalization in the department. And within 6 months of arriving, they had passed legislation to regionalize healthcare. So it was a bit of a surreal kind of experience for me as an academic going into the environment and having this kind of thing happen. So anyway, Ralph Klein became leader, and in 1994 you see 17 regional health authorities replacing approximately 200 hospital and public health boards, although I was reading something last night that it was closer to 250 of these local boards. So that represented a significant and fundamental structural change in the healthcare system that basically, in a lot of people's minds, came out of nowhere, because the government at one point in time seemed to be going in a completely different direction, and then they did almost a 180 overnight and introduced these regional health authorities. So again, the reason for this, Klein ran in 1993 provincial election on a platform of fiscal austerity, and there was a growing threat from the Reform Party that if Alberta didn't do something to get its deficit and debt under control, that the Reform Party was going to start up a provincial wing in Alberta and challenge the ruling dynasty. So the government either had to do something about this, or they were going to face a significant electoral threat, in the same sense that we now have a fairly right of center party, the Wild Rose Party, that is mounting a significant challenge against the Conservatives. So if we end up having a change of government in Alberta, in all likelihood, it's going to be a further move to the right, which, in my opinion, would not be a good thing for any of the things that have been going on in Alberta. But so Klein, once he became leader, he had a series of roundtables on the state of the economy, which basically were used to sell the idea to Albertans that they had to eliminate the deficit and debt, and they had to do it fairly quickly. He then moved to pass legislation which would require the government to do that within their next electoral mandate. And that's the way things sat when they went into the election. So, not surprisingly, they were returned with a majority, and as soon as that was put to bed, they initiated a second set of roundtables, this time specifically on healthcare. And interestingly enough, according to what they say they heard at these roundtables, they heard people say that they wanted something like regionalization. So where previously they had heard from those processes during the late 1980s that there was no way people wanted that, now all of a sudden the population seemed to want it. So how much of this was orchestrated and how much of it was real, you know, we'll never really know. But that was the line of argument that was put forward, and through the document that summarized all this, they also called for a consumer-first approach with maximum access and choice, and then they put together a 3-year business plan, which called for 20% cuts across the board. And that wasn't unique to health either. The government itself was saying at the time they were going to cut 20% in all program areas. So, but in healthcare, if you cut 20%, you really feel it. So, in March 1994, legislation was passed to disestablish the existing hospital, public health, and continuing care boards, with some exceptions. The Catholic boards were exempted. Cancer and mental health continued to be governed at the provincial level. Physician services and pharmaceuticals were not included in regional budgetary responsibilities. So think back to what I said to you a few minutes ago about dominant and challenging interests. And the regional health authorities also inherited the previous local debt that had been accumulated by hospital boards, while they were also having their budgets cut by the new government. And interestingly enough, again, the boards were put together, and they're basically given 6 months to put together business plans and get up and running. So anyone who's ever been involved in a process of business planning knows that 6 months is not a lot of time to get all that done. So it was very much hit the ground running. And in part this was because of a page that had been torn from the playbook of Roger Douglas in New Zealand, who had written a book about health reforms in New Zealand, basically saying that if you want to get major reforms done, you need to move fast and hard before the opposition has time to mobilize. And that's exactly what they did in Alberta. They basically steamrolled over the hospital sector before any significant opposition could be mobilized, particularly from the public. Because we know that in the past, whenever, well, and even in recent times, whenever something happens around a hospital where it's going to be closed or where they need to have something fixed in a hospital, the public is fairly quick to mobilize around that. And politicians know it. So in 1997, the government again won a majority. In fact, their majorities seemed to get bigger as they went along. And by 1997 as well, the price of oil and gas had bounced back, so the significant cuts in expenditure to healthcare and other sectors had actually started to wind down by this point. So the government had money to spend, and they were now starting to spend it again, as was the federal government starting to look at spending things by the end of the 1990s. So they started with a number of one-time funding announcements to allow the regions to discharge their debt, and that would go on over the next couple of years. They also, however, undertook several reviews of individual RHA boards, particularly rural boards, and they ended up actually replacing some of the boards by administrators. So they found instances of fiscal mismanagement, and they replaced the boards. And there was also a report done at the time by an academic at the University of Alberta, Richard Plain, looking at the cost effectiveness of the regional health authorities based on the information that they had at the time. And what Richard found was that the major health regions, Calgary and Edmonton, were actually feeders from the other regions for a significant number of patients. And the way the funding formula was set up, the regions were not actually, the region sending patients were not actually sending money with those patients to Calgary and Edmonton. So Calgary and Edmonton were having over expenditures in terms of a number of the services they provided, particularly surgical services, by as much as 20 or 25%. And that was because they were getting 20 to 25% of patients getting sent in from the rural regions to get surgery. So that became, again, an issue that needed to be addressed by the government. In 2001, the government first allowed the election of partial election of regional health boards, which was something they had promised to do all along. They subsequently abandoned that a couple of years later, saying that elections didn't make any difference. In 2002, the minister approved business plans but rejected a couple, and then in 2002, later in that year, he announced that the number of RHAs would be reduced from 17 to 9. So interesting that the original number that they talked about, the 9, took them a while to get to it, but they eventually got to it. And the backstory behind that was that, again, in order to move forward with the reforms initially, and not to alienate too many of the rural constituencies, they had to create a number of extra regional health authorities in order to keep the rural areas happy. So they ended up with 17 instead of 9. In fact, originally they were only going to have 15, but there was some dispute among several rural regions, which resulted in the creation of 2 additional rural regions, just so that they could get it done. So again, in order to get things done, you may make these kinds of compromises and then come back another day to try and deal with some of these things, especially if it turns out that you're not getting what you think you should be getting out of the regions, particularly saving money. So the new RHA boundaries were finalized in December. So it was kind of a ready, fire, aim process that happened in terms of initially creating regions where there was a political pressure to get things done and to be able to then go back to the voting population and say we have slain the debt. And to the credit of the government of the day, they were able to successfully do that. However, the caveat there is that they had luck on their side and that the price of oil and gas rebounded at the right time, which meant that a lot of the cutting that they said they were going to have to do, in the end they were able to back away from because they had new revenue coming in. So you know, luck in life is a big factor. So now, fast forwarding a bit to the 2004 election, which again returned the Progressive Conservatives in a majority, and this was Ralph Klein's 3rd election. In 2006, he retired as Premier after a marked decline in his support in the party itself. So he went from 90% to 55%. So I mean, some people will consider 55% enough to keep going, but apparently he didn't. It was aim high or quit. But he was planning to retire anyway, but he was planning to stretch it out to about 2008 before he actually retired. I think there was something to do with the, yeah, I'm not sure why, but he was stretching it out until then, and so the process of him leaving became a little messier than it might otherwise have been. Anyway, Ed Stelmach becomes the party leader and Premier, elected in 2006, and he wasn't actually elected until the 2008 provincial election. And immediately after the election, there was an announcement that the remaining 9 health regions would be collapsed into a single governance and management structure. So one of the questions, you know, that continues to keep me up at night is whether or not from the get-go the government actually was planning to centralize the governance of healthcare, or whether it has just been through serendipity that they have ended up with a single health authority. In other words, whether they set out honestly to see whether health regions would work. And having not been satisfied with the way they worked, they have centralized, or whether they simply saw regions as a way station along the way to centralizing the delivery of health services, or the governance of health services. So that's an interesting question. We may never be able to answer it, of course, but it certainly is an interesting question. So in 2009, Alberta Health Services is born. Stephen Duckett is the inaugural CEO. And a little over a year later, Stephen Duckett resigned as CEO. And for those of you who don't know the story about that, just Google Stephen Duckett cookie and you will find out why. I actually was going to insert something into the presentation here that we could click to, but I wasn't sure whether the technology would let us do it. But since you've all got your iPads, I'm sure in the audience, you can sit there and do that now as I continue to ramble on here with the story. So in 2010, Duckett resigns as CEO, and then he is replaced eventually by Chris Eagle, although in between there they appointed some sort of senior, no, sorry, a senior administrator was brought in June 2013 to replace the board. And then Chris Eagle resigned later in that year as the acting CEO, and then they've now got a permanent CEO. They had another acting CEO in between, but the bottom line is that since about 2010, the governance has been a complete mess and a disaster. And I hope that my remarks to follow from this point on will offer some insights into why that has been the case. Yeah, it's quite sad actually the way things have gone, because Stephen Duckett perhaps was not the best person to put in front of the camera to comment on matters, but in terms of his expertise about the healthcare system, I'm not sure you could actually find anybody who has the kind of expertise that he has. And again, if you look at his CV and look at the things that he's published, the guy knows what he's talking about when it comes to managing the healthcare system. But apparently he seems to know very little about the political aspects of the healthcare system. I use one of his books actually for one of the courses that I'm teaching now, and he's a good writer. So, the politics behind what happened after Klein left. First of all, towards the end of his run as premier, Klein became increasingly reliant on the CEO of the Calgary Health Region, Jack Davis, who had also been the principal secretary to the cabinet in Alberta. So he was a career public servant who had ended up in the Calgary Health Authority, but he relied quite heavily on Jack Davis for his advice about how to proceed in the healthcare system. So once Klein was gone, Jack Davis was still there, and Jack Davis still continued to speak quite vociferously in public about the problems with the healthcare system, namely that they needed to give the regions more money. And the new political executive was not particularly pleased about that, especially when those kinds of statements started coming out in proximity to the 2008 election. So it doesn't come as a great surprise then that the new political executive was not particularly enamored with the leadership in the health regions. And of course there were other concerns as well that had been brewing for some time, so concerns about financial mismanagement and continuing deficits. So I talked about some of the rural regions that have been reviewed and had been replaced by administrators and that kind of thing. But there was also the continuing reality that despite the fact that the government was putting these periodic infusions of money in to help the regions get rid of to manage their deficits, the regions kept running up deficits. And this was almost like the old game that hospitals used to play with provincial governments, where the provincial governments would give them a fixed budget, and they would go over budget, and then they would go back cap in hand and plead for more money. And of course, that puts the politicians in a difficult position, because if you don't come up with that additional money and the emergency rooms are backed up, guess what the public's going to think? Guess who the public is going to blame for that? So it's an old game in healthcare, and despite the naive belief that politicians might have had that by establishing health regions they could get away from that old game, the old game did in fact return, and I don't think it ever really went away. So you had that. You had concerns about variation in rates of certain surgical procedures, and we know from the literature that has to do with the preferences of the surgeons doing the surgeries more than anything else. So geographic variation has been well studied in healthcare. And then the continuing bitter rivalry between Calgary and Edmonton, which was highlighted around this time period by the infamous quadruplet incident, where a mother who needed to deliver quadruplets could not get into a bed in Calgary because there were no beds to be had in Calgary, and they ended up flying her, airlifting her to Montana, where she had her quadruplets. And afterwards they found out that there had in fact been a bed available in Edmonton, but that because there was such rivalry between the two regions, that this is what, so that kind of brought everything to a head, but it was well known. You know, I've been in Alberta for 20 years now, and I know that, and it's not just in terms of healthcare, it's everything. If you give something to Edmonton, you better bloody well give something to Calgary as well, or you're going to pay the price politically.
Can you hear me?
Yes.
I'm sorry to interrupt, but please remind the other people at your table that you have live microphones. We're hearing other conversations and paperwork. And if it's the other Regina location, can you mute your microphone? Everything is coming across at our end. We can hear everything else, including you, sir.
Okay.
Must be the other Regina location.
Not everybody here is being very quiet. They're mesmerized or falling asleep, one or the other. So, Alberta Health Services was designed to reduce bureaucracy and end this rivalry. I mean, just staying on the rivalry piece for another second, you know, I was involved in evaluating primary care reforms that took place during the 90s and the early 2000s. And there was all kinds of innovation going on, and it's not just in primary care, but in other areas as well, where in one of the regions they will do something really innovative, but it never seems to diffuse outward to the rest of the system. So the result is that governments at both levels, federal and provincial, are sinking all kinds of money into funding these kinds of innovations. But then because of the rivalries that are going on, they never spread out across the whole system.
Sorry to interrupt. It seems that your mic is muted.
No, it's not.
Not as far as we know. Is it working now?
Yeah, it's working now.
Okay, it must have just cut out or something because of the internet. Anyway, the bottom line is that governments, again, were sinking tons of money into trying to get innovation in the system, and one of the reasons that they weren't getting innovation is not because innovation wasn't occurring, but because of the politics, the local politics really, the innovations could not diffuse outward. So they were hoping that by creating one giant structure for governance, that this in fact would get around this. So the other things that we've seen in terms of the politics is that since, well, actually to talk about to reduce bureaucracy part, first of all, since Alberta Health Services came into being, there have been huge concerns about the size of the bureaucracy. In fact, at one point they had I forget what the total number was. Was it 80 VPs, or it was several dozen VPs. So you know, in terms of the way it appeared structurally, although Stephen Duckett in one of his articles makes a counterclaim in terms of overall expenditures, but the appearance or the optics was that in fact you had a huge central bureaucracy, top heavy, and yet you were not seeming to make the right decisions to get the services working properly at the point of delivery, because wait times continued to go up. Access to primary care physicians, still not good. All those kinds of things that you would hope would be solved by this continued unabated, really, with the creation of Alberta Health Services. So there were also concerns by doctors about political muzzling. In fact, they had an external review around that, which basically confirmed that as an issue, that physicians were in fact being pressured to not speak publicly about some of the things that were going on in the system, which of course goes directly against the professional autonomy of doctors. So that did not go over well. The pay at risk fiasco, which happened laterally, in fact just before Stephen Duckett was dismissed, there was a situation where the contract that Alberta Health Services had with senior management was that they would get performance bonuses for hitting their targets, so to speak. And this became a problem for the provincial government when they were doing cutbacks to to other sectors of the economy. And the provincial government basically said to, excuse me, the Alberta Health Services board, you're going to have to cancel those payments to senior management. And Alberta Health Services took the position that they were contractually obligated to those managers to pay them those bonuses, and if they didn't, that the managers could take them to court. And the government basically said, okay, well, we're going to give you a couple of days to reconsider that decision. And the board stuck to their guns, I think correctly, actually. And the government came in and basically eventually removed the board and replaced them with a single administrator, as I mentioned earlier. And then finally, and the top-heavy administrative structures argument was actually demonstrated again through an external task force that was set up. So Alberta Health Services, which supposedly was going to solve a whole bunch of problems, when it came out of the gate and a few years out of the gate, it didn't appear to be solving very many problems at all. In fact, it appeared to be creating new problems that previously weren't there. So that's kind of where things are at. And now, of course, we have a new CEO, and we have a new minister and a new premier, and they have all made announcements recently about getting rid of bed blockers by opening up more spaces for long-term and continuing care. An announcement which was made by the previous administration 3 or 4 years ago. So what happened? Like, you would think that with this new high-performing organization that they would have fixed that problem. And yet the emergency rooms are as jammed up as ever, to the point where the prominent emergency room doc, Dr. Paul Parks in Lethbridge, has publicly said that within the last week or so, or no, the last couple of weeks, said that the emergency medicine system in Alberta is on the point of catastrophic collapse. That's the way that he has defined it, and to translate it into terms that my kids would understand, that's like epic fail, right? So how could this be? So what the heck happened here, right? With all this effort, all this money that has been invested in improving the governance of the system, why is it that we don't seem to be able to get it right, and that the government seems to be reeling from one crisis to the next. Well, coming back to talking about dominant and challenging interests, first thing to think about is that that the government has for some time been trying to rationalize the system, and that they haven't had the full cooperation of the health professions, particularly physicians, in terms of that rationalization of the system. In fact, it's kind of interesting. I used to play hockey with an emergency room doc, and we obviously, we're sitting around having a beer after the game. We used to chat about some of this stuff, and he was quite hopeful when Stephen Duckett arrived that maybe he was going to listen. So I can imagine that when Chris Eagle took over, and Chris Eagle was actually a doctor, the doctors must have thought that, well, things are finally really going to get fixed because they've got a doctor running the system now. Apparently that didn't quite work out that way, or Chris Eagle realized that doctors running the system probably, or that as a doctor he probably didn't want to be running the system, since a lot of running the system had less to do with actually practicing medicine than a lot of other things. So broadening things out a bit and think about neoliberalism. First of all, we have neoliberalism and accountability. So this is where the role of ideas starts coming in. So going back to the Rainbow Report, greater personal responsibility and accountability for managing our health and health resources. We need to return power to choose and decide closer to Albertans and to communities. There must be coordinated and integrated programs and services locally planned and directed. A serious redistribution of power. So that was the Rainbow Report. Again, the Rainbow Report. The privilege of choice. Have the capacity to recognize that which is just and proper and master the balance between individual right and societal good. Albertans will take greater responsibility, will exercise greater control, will be more accountable for our actions and personal well-being. So you can see a neoliberal message underpinning all of this. Consumer choice, facilitate consumer choice and responsibility in health resource utilization. So there was that set of ideas floating around. There was also this, which is new public management. The provincial government should concentrate its efforts on setting long-term goals, developing priorities and policies, establishing overall standards, ensuring interregional coordination. So basically what Osborne and Gabler in their book referred to as steering, not rowing. So this was all the rage back in the 1980s. It started in Europe, spread to the United States, and eventually made it to Canada. So we have this idea of new public management. And new public management was basically about decentralizing responsibility, creating internal markets. So in other words, creating these organizations which were going to operate within fixed budgets. And ideally, they would compete with each other to improve quality, even though they were public sector organizations. And Britain, of course, went the furthest with this in the development of their internal markets in healthcare. But they tried it here, or they were contemplating it here too. And the problem with doing it here is we don't have large enough markets. As a health economist that I know at the University of Alberta said to me, he said, let them bring on the private providers in the Alberta market and see how far they get. Because at the time there was only between 2 and 3 million people in the entire province, right? So in terms of having private HMO type companies come in and compete with each other in a market like that, there isn't enough of a market to actually have any competition. So any idea that new public management was going to play out that way actually didn't go very far, although they did decentralize to regions and give them fixed budgets and that kind of thing. So there was that going on. The other thing that happened as well is new public governance. And this was a belief that there needed to be a change in the relationship between politicians and bureaucrats. The bureaucrats for too long had held the upper hand in terms of running the show, and politicians were going to basically take back the night, so to speak, from the bureaucrats. So there were a number of things that happened in Alberta, and we'll talk about that in a few minutes. But the important point to note here is that new public management is talking about a decentralizing process, whereas new public governance is actually talking about a centralizing process. So again, there was a conflict or a competition of values there that goes a long way to explaining what has gone on both with the regional health authorities and more recently with Alberta Health Services, is that they can't seem to sort out which set of values they want to take precedence, right? So it's back and forth and back and forth. And again, this has nothing to do with, you know, the micro politics of healthcare or even about dominant and challenging interests, because doctors in all this have been kind of sidelined while the government has been fighting it out at the provincial level with the board and the senior managers. So regionalization, again, this was the idea that it would encourage all these things.